So reviewing the gonadotropin-releasing hormone specifically, remember that it is in males and females, so it has a role in ovulation and spermatogenesis. So this one I drew, here's the testosterone, so male system, and here's the testes and the ovary. So what we're seeing here is just remembering that in both, the hypothalamus is releasing the GnRH to the pituitary. In both, LH and FSH are players. In males, the LH and FSH is coming and it's causing spermatogenesis. And in females, the LH and FSH is coming, maturing the follicles, causing estrogen synthesis, then causing ovulation. So right here, remember that it's always pulses. Follicle stimulating hormone in women always comes first before luteinizing. And you can remember that because it's stimulating the follicles. And then the other one is the corpus luteum. That'll hopefully help you remember which order they're coming in. The FSH again is causing the follicle maturation and that first half of the cycle, estrogen synthesis. LH is stimulating the ovulation. And then in men, the FSH is stimulating spermatogenesis. The LH is stimulating testosterone synthesis, which we talked about when we looked at that cycle for men. So when you look at this, what I want you to see is this GnRH pulse. Without a GnRH pulse, you don't get FSH, you don't get LH. If you're a woman, you don't get follicle maturation, you don't get estrogen synthesis, and you don't get ovulation. So if you screw up GnRH in a woman, none of those things are going to happen properly. If you screw up GnRH in a male, you're not going to get spermatogenesis and you're not going to get testosterone synthesis. So you screw up GnRH in a male, you get all those issues. So when we look at it, even though the estrogen, progesterone, and testosterone seem like they're doing different things, everything, whether it's male fertility or female fertility, you've got to have that GnRH, LH, and FSH working. With infertility, it may seem weird to have the same drug targets for male infertility and female infertility sometimes. They're the same pathway. And so you look at them as they're acting in the same pathway. It's just at the bottom, it's a different organ that you're working on. So hypothalamic amenorrhea, menorrhea meaning menses, amenorrhea, A is always not or bad, right? So amenorrhea, not having menses because of your hypothalamus. So that is when the reason that you have lost a menstrual period and lost that cycle. So it's not just the menstrual period, but it's also the follicle stimulating and ovulation and everything. So it's just the cycle is messed up, is happening up in the hypothalamic pituitary part. And so anything that inhibits GnRH, LH, FSH release is going to stop ovulation. So Dr. Uziali brought up something that can inhibit GnRH, LH, FSH release, or can increase them so much they don't cycle anymore, are things like tumors. Sometimes people have damage from a TBI and actually damages the hypothalamus or pituitary. So things that are physical can impact the hormonal cycling there. But when we talked, I just keep talking about that negative feedback inhibition, right? If you have too much testosterone, that's going to come back and it's going to inhibit GnRH, LH, and FSH. Same thing with estrogen and progesterone. If you have too much estrogen or progesterone, it's going to come back and it's going to inhibit GnRH, LH, and FSH release. When you're looking at menstrual cycle disorders and infertility, not only could you look at, do you not have enough estrogen, progesterone, and testosterone, then you won't have everything happen. Or you have too much of it, and then you won't have everything happen. There's some additional hormones that if you're doing, like if you were taking A&P on this, we'd be talking about, but you're not. It's complex enough already. So how can we induce LH and FSH release? Say you have someone who's not making FSH and LH. How are we gonna increase the production of LH and FSH?
Gonadotropin release.
Do you guys down here, when you look at an agonist, what could you give someone that would induce LH-FSH release? Something that mimics the action of GnRH. So maybe your body's not making GnRH right. You might be able to use a GnRH agonist. Maybe your body's not responding to GnRH, you're making it, but it's not responding right. You could even just you could use FSH and LH. You'd have to time them right, but you can use either the actual hormones themselves that have been synthesized or purified, or you could use agonists that are not the actual hormone. Or if one of the problems you're having is feedback inhibition by testosterone, estrogen, or progesterone, then maybe you can reduce the levels of testosterone, estrogen, or progesterone to release the pathway and allow your body to go, oh yeah, I can do this. I can make GnRH, LH, and FSH. What we just said is you can give your own gonadotropins. You can give GnRH, you can give follicle stimulating hormone, you can give luteinizing hormone. That was one of our options. Is you're not making them right, just give it to you. And so if you give GnRH, you have to give it in pulses. If you gave it to someone and you didn't give it in pulses, it wouldn't work. Because remember, those receptors are going to desensitize if you're giving it all the time, not in pulses. So you got to do the pulses. Or you can just give the gonadotropins themselves, FSH and LH, and you're going to get what you want. When we got to this slide, we said there's a couple things you could do. You could reduce feedback inhibition, or you could replace the hormones or put in an agonist, correct? This one was actually replacing the hormones. That was that one option, replace the hormones. And then the other option was to decrease agonist, decrease the feedback inhibition. Here's what we're seeing when we're using the drugs to pulse GnRH. You can replace that GnRH a couple of different ways. There's a drug called gonadorelin, Factril or Lutrapulse. Does Lutrapulse make sense? It's GnRH, it's got a pulse. It's a pulse pump. It's actually just an GnRH agonist, and you put it like any kind of pump delivery system, but instead of a constant delivery, it pulses it. All that's going to do is activate the GnRH receptors, stimulate ovulation. So if you give an agonist pulsing, that's going to increase ovulation, correct? What happens if you do the opposite and you give a depot agonist? Is that going to pulse? So that's actually going to decrease ovulation. So sometimes you want to block ovulation. If you want to block ovulation, you could give this depot agonist. And so nafarelin is the depot agonist. Another way to block ovulation is to give a GnRH antagonist, because that's also going to block FSH and LH release. And ganirelix is that drug. So what I want you to see from this is you can play with GnRH release to cause ovulation or to block ovulation. You can do either one. But the key is not just whether it's an agonist or antagonist, but also if it's an agonist, are you pulsing it or not? Because that's where people get the most confused, is why is this agonist stimulating ovulation and this agonist blocking it? And it all has to do with whether it pulses or not. So two different ways you can block it: depot agonist or an antagonist. We're moving along. Okay. Get ovulation to occur. We want that GnRH pulses. So we talked about drugs that can give GnRH pulses to cause ovulation, or drugs that can continually or block GnRH so that you don't have ovulation. We talked about how the other reason that you're not having ovulation might be that you have too much estrogen or progesterone or testosterone around, and it's going back up and it's creating feedback inhibition. So we talked about GnRH agonists that we could give. The other thing that we can talk about is, what if you do have too much estrogen? What if that is blocking GnRH? And so you guys already told me yesterday what you would do if you had too much estrogen. You'd block aromatase. And so aromatase blockers are letrozole and anastrozole. And I like letrozole, you can remember it because it's fem, aromatase, femara. They're non-steroidal, they're just aromatase inhibitors. They do exactly what you would expect. They inhibit that enzyme, reduces estrogen synthesis, reduces the feedback, and restores ovulation. So the other thing that you can do, you can use those aromatase inhibitors, but you can also go in and you can be a little bit more sneaky and you can use a SERM. I could use an aromatase inhibitor, but that's going to block estrogen everywhere. And we don't necessarily want to block all your estrogen production. So let's say we want something that's going to block the estrogen or reduce estrogen effect in the HPG, but not reduce it in your bone or your lipids and stuff like that. So we have clomiphene or Clomid that is a selective estrogen receptor modulator. And what you need to know about its mechanism is it acts as an antagonist in the hypothalamic pituitary, because that's how it's helping us. It's good because it doesn't block estrogen everywhere, but really what it's doing for ovulation is it's being an antagonist in the hypothalamic pituitary to reduce that negative feedback and release ovulation. And so in the table here, those are all in italics, so you're not memorizing what it's doing at these other tissues, but it's reminding you that a SERM is going to have different effects at different tissues. Polycystic ovarian syndrome is the most common, that I'm aware of, the most common form of female infertility. It is not only an infertility issue, but is also just a medical issue in other ways that you might be treating even if you aren't concerned about fertility. So we're going to talk pretty quickly about basic pathophys and some treatment agents, the pharmacology of them, what the symptomology is known, but honestly, they're still really kind of trying to figure out why it happens. They know what's happening, but not why it starts, not why is this happening to one person. The principal features are either don't ovulate or you don't ovulate frequently or regularly, that you have cysts in your ovaries, and that you have high testosterone levels. So if we're looking at this, the cysts mean, when we talk about that, that means follicles that have matured mostly, but have not ovulated. So if you've got this pathway and you're releasing GnRH and you're releasing FSH and you're releasing FSH, your follicles are starting to mature, but then you don't release LH, or the follicles never mature quite enough to ovulate, then you're going to be stuck with here in this diagram, these ovaries where you're growing those follicles, they're maturing, and then they don't ovulate. And so you've got little matured follicles that are now there and they've turned into cysts. So you've got various different levels of dysregulation of that hypothalamic pituitary hormonal cycle. These are the principal features. So that's what I want you to know, that reduced or missed ovulation, the ovarian cysts, and high testosterone levels. You may also see effects on LH and FSH. You may also have high estrogen and irregular menstrual cycles. But you would expect all those if the whole pathway was disrupted, right? If your GnRH, LH, FSH pathway was disrupted, you wouldn't be surprised that your menstrual cycles would be irregular. You wouldn't be surprised that your estrogen levels might be too high or too low. You're seeing these hypothalamic pituitary effects. You're also often seeing androgenic effects. And that's because many people with PCOS have high testosterone levels. If your testosterone levels are high, you're going to have pro-androgenic effects like increased acne, increased body hair, and potentially thinning of the head hair if you have male pattern baldness. That's what I was looking for. So you're looking at someone and you're like, oh, wow, they're having abnormal LH, FSH, they're having irregular menstrual cycles, they have cysts. Oh, that all makes sense that their hypothalamus and pituitary cycle isn't working great. Oh, they have androgenic effects. That makes sense. Their testosterone levels. You can also see a large number of people with insulin resistance or obesity and sometimes people with non-alcoholic fatty liver. That is the most common cause from the information I was looking at for female infertility. Why so this happens to someone, we don't know. From a pharmacological standpoint, it's really nice because it all kind of makes sense in terms of how you would address it physiologically. If you have reduced ovulation, ovarian cysts, and the high testosterone levels, and you're looking at your symptoms, you're like, okay, we have a problem of high insulin resistance and high insulin levels. That's causing that overweight, the obesity, the patches of dark skin, increased risk of diabetes. We had high androgen levels. That's causing the hirsutism, acne, and hair thinning. And we have inappropriate or disrupted gonadotropin secretion, and that's causing changes in menstrual periods, menarche, and ovulation, infertility, and cysts. So I kind of break it down into, we have principal features, 3 of them, and then we have 3 physiological problems, like you could measure in a blood test. So when we look at how that works with PCOS, you're looking at someone who comes in with high insulin, and insulin actually increases androgen production. So the ovaries have aromatase, most of that testosterone's going into estrogen. But if it doesn't go into estrogen, or if you just have so much testosterone that you keep some, even if you are making estrogen, whatever the problem is in the ovary, you're making a lot of androgens. And the ovaries can do that. And then with the testosterone comes up. And so we're seeing a testosterone-driven inhibition of the GnRH. So T is then what blocked that. The GnRH, to some extent, in some people is going to block FSH, but in a lot of people, the FSH is going to stay somewhat okay. If the FSH stays somewhat okay, that's when you're going to start maturation or start development, but you're not going to have LH released. And this is just how it works in PCOS, right? And so in this case, you have enough FSH to start development of those oocytes, the follicles. You don't get the LH, so now all those follicles are just sitting there. Without that corpus luteum, your body is not necessarily following that progestin build. So remember, at the very beginning of the cycle, you had estrogens building, then the second half you had progestins retaining. And then, like Dr. Mike said, if you don't get pregnant, the progestins drop. If you do get pregnant, the corpus luteum stays alive and progestins stay around. That's going to keep the pregnancy. If you don't form a corpus luteum, are you going to have progesterone in that last half? No. So if you don't form a corpus luteum, you're not going to have that progesterone there. So if you don't ovulate, you're not going to get a corpus luteum. So you've got GnRH problems, you don't ovulate, you don't make a corpus luteum, you don't keep progesterone, and you don't have the normal drop either. So you're not going to then have the normal menstrual period of that cycling. So that's where the menstrual period is being changed and where that ovarian cycle is being changed. So the last slide I have before we then move over to Dr. Nuziali for the rest of the lecture is I want you to think about how would you treat PCOS based on what we know. We said we have insulin resistance and high insulin levels. What could you do? You had to pick a drug out of your drug cabinet. Metformin. Seem reasonable? Yep. So let's say metformin. How about high androgen levels? Could you decrease androgen effects? A lot of different ways we could do it, right? We could use an androgen antagonist. We could block 5-alpha reductase if it was DHT that we were worried about. We could try to figure out a way to feedback inhibit so that we don't make as much androgen. There are a lot of different ways we could address that, right? But whatever drug we use to decrease the androgen effects. And then if we had inappropriate gonadotropin secretion, we can just take over. Just take over the GnRH, LH, and FSH cycle. Give those gonadotropins, do something that's going to put it where you want it to be. And sometimes in people with PCOS also have high estrogen levels. So it's almost always high androgen levels that are causing feedback inhibition. But what if you also had high estrogen levels? That's even more feedback inhibition. I could treat my high androgen levels, but if I have a high estrogen levels, I need to look at that too. So there's a lot of different drugs that you could use here. You could use metformin. You could use some contraceptives because we had some progesterones that blocked androgen receptor antagonists. You guys remember which one that was? It was one progesterone that had an anti-androgenic activity. Drospirenone. And or you could use here an anti-androgen, which were any of the antagonist or 5-alpha reductase inhibitor could be used. And when you start looking at gonadotropin secretions, how could you hijack the problem? You could use contraceptives and just say, I don't trust you, hypothalamus and pituitary. You're not able to control this properly. I'm just going to use a contraceptive and control estrogen and progestin alone myself. Or go in with gonadotropins, or go in with something that's going to reduce estrogen response, the clomiphene or estrogen synthesis blockers. Not all of these are going to cause ovulation, like the oral contraceptives, things like that won't cause ovulation. But remember, we're saying, and Dr. Nuziali is really going to hit, one problem with PCOS is infertility and ovulation. But people can have pain, menstrual irregularities, insulin insensitivity. There's like so many other things that come with PCOS that you may want to treat that even if you don't want to get pregnant. And so things like oral contraceptives might be in here even if you weren't trying to ovulate. This is just how do we normalize this system?